This meeting is now being recorded.
Good afternoon and welcome to my capstone final defense. I am Judy Blauwet. I am the Senior Vice President of Hospital Operations and CNO at Avera McKennan Hospital in Sioux Falls. My capstone project is titled Barcode Medication Administration System, an Intervention to Reduce Medication Errors. My sincere thank you to my capstone committee chair, Dr. Elaine Foster, whose weekly advice, guidance, and support was always valuable and timely, and to my two additional committee members, Dr. Judy Burkhardt and Dr. Linda Herrick, for their ongoing guidance and support throughout my capstone project. Medical errors claim as many as 98,000 lives each year and are the 8th leading cause of death in the U.S. Up to 7,000 of these deaths each year were attributed to adverse drug events from medication errors. Additionally, the cost to treat patients who experienced adverse drug events as a result of medication errors was $3.5 billion a year. These startling facts were released by the IOM, or the Institute of Medicine, in a series of reports beginning with its landmark study in 1999, To Err is Human, Building a Safer Health System, followed by the Quality Chasm series in 2006. In addition to the IOM reports, Bailey reported that 5% of malpractice claims are due to medication errors, with an average jury award of over $600,000. Beyond the harm to patients, staff, and organizations, medication errors result in human guilt and tragedy to professionals, as reported by Alicia in 2011, where a nurse of 20-plus years of experience with an impeccable performance record committed a medication error of administering 5 times the prescribed dose of a medication to an infant. 6 days later, the infant died. The nurse subsequently lost her job, lost her license, and 6 months later committed suicide, leaving behind 2 teenage children. A double tragedy as a result of an unintended medication error. These startling facts provided the impetus for my study on the implementation of a barcode medication administration system as an intervention to reduce medication errors. The study site hospital, a large tertiary care facility in the Midwest, had a problem with medication errors consistent with published reports by the Institute of Medicine and Barker et al. In 2002. According to its 2012 quality report data, this facility experienced 576 medication errors in 2012, of which 404 had the potential to cause harm. The background information for the study provided 3 key points regarding medication errors. The first is there are 4 phases in the medication administration process: prescribing, preparation, dispensing, and administration. The administrative phase is deemed to be the most critical, as it is the last phase in the medication administration process and has the potential of identifying and intercepting medication errors that may have occurred in the previous 3 phases. The second key point is that of the 4 phases, the majority, with a range of 36 to 44%, occur at the administrative phase. The third key point is that a barcode medication administration system and process, or known as BCMA, was found to be effective in reducing medication errors, as evidenced by Poon et al. In 2006, Palenti et al. In 2007, and DeYoung et al. In 2009. The implementation of a barcode medication and system and process and as an intervention to reduce medication errors was the focus of this study. The purpose of this study was to measure and describe The effect of implementing a BCMA system and process which was integrated into the electronic medical record on the incidence and severity of medication errors at a large tertiary care hospital in the Midwest. The measurements and subsequent descriptions focused on the outcome of the number of medication errors as well as on the severity of medication errors. The significance of this study was the potential opportunity to reduce the incidence as well as the severity of medication errors. This nurse leader and researcher felt she had the responsibility, the authority, and the accountability to pursue this study as a means to improve patient, staff, and organizational safety. The nature of the project was a quantitative retrospective study across 15 inpatient units at a large tertiary care hospital in the Midwest. The focus was a comparison of the incidence and severity of medication errors before the implementation of a BCMA system and process to after the implementation of a BCMA system and process. The research questions for this study were twofold. First of all, does the implementation of a BCMA system and process within an EMR decrease the incidence of medication errors? And secondly, does the implementation of a BCMA system and process within an EMR decrease the severity of medication errors? The theoretical framework for this study was the Donabedian theory of quality health care. Donabedian, a physician and researcher at the University of Michigan, developed the theory of quality health care, proposing that the manner in which we conceive of health and our responsibility for it makes a fundamental difference in the concept of quality. The Donabedian model for healthcare emerged from this theory, where Donabedian identified three dimensions that can be used to assess quality of care: structure, process, and outcomes. Using the Donabedian model, the dimension of structure provided the framework for the study and included elements such as the organizational strategic plan and budget, as well as the BCMA project plan. The dimension of process operationalized the study and included elements such as convening the stakeholder group who participated in developing the current and future state maps, as well as implementing the BCMA system and process. The dimension of outcomes identified the desired goals of the study, a decrease in the incidence as well as the severity of medication errors. Key definitions for the study included a medication error, which was defined by the National Coordinating Council for Medication Error Reporting and Prevention as any preventable error that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. BCMA is defined as the barcode medication administration, which is a system and process whereby a handheld scanner is used to scan a 2D barcode on the patient's wristband as well as on the medication packaging prior to documenting administration on the electronic medical record. The Donabedian model is defined as the framework for evaluating healthcare services and quality of care using the components of structure, process, and outcomes. The incidence of medication errors is the actual number of medication errors reported, while the severity of medication errors, also defined by the NCC MERP categorization and indexing tool, provided an algorithm embedded within the tool which created a framework for categorizing and indexing medication errors, considering factors such as whether the error reached the patient and if the patient was harmed, to what degree. The algorithm provides 9 categories ranging from Category A, defined as a circumstance or event that have the capacity to cause harm, to Category I, defined as an error occurred that may have contributed to or resulted in the patient's death. 6 themes emerged from the literature review. The first was an overview of medication errors, which began with the landmark Institute of Medicine report of 1999 and the Quality Chasm series published in 2006. In addition to the IOM report, Myers and Massetti in 2011 reported that a medication error resulting in an adverse drug event increases the cost of care by $8,750. Paradis reported similar findings suggesting that a medication error resulting in an ADE or an adverse drug event extended a hospital stay by 22%. To further add to the concern, DeFeature in 2007 suggested that medication errors are underreported by a range of 10 to 47%, while Yelanimo in 2007 reported that the nurse is most at risk as the majority of medication errors occur at the administrative phase. The second theme was extensive use of technology to reduce medication errors, as reported by Franklin et al. In 2007. And the most recent studies focused on the benefits of what is known as a closed-loop system, meaning the BCMA system and process is embedded within the organization's EMR. Hassan et al. In 2010 provided the theme, which is the importance of process redesign as part of implementing new technology and the engagement of key stakeholders in the process redesign. The fourth theme is that BCMA is effective as an intervention to reduce medication errors across a variety of settings, as noted in medical surgical units in studies by Hellmans et al. In 2009, Paletti et al. In 2007, and Poon et al. In 2010. Across the NICU setting, as in the study reported by Morris et al. In 2009, while DeYoung et al. Reported studies or published studies across ICU settings. Sikowski et al. In 2008 completed and reported a study across community hospitals. And also of interest, studies of the value and the use of BCMA as an intervention to reduce medication errors occur even on an international level in studies by Franklin et al. In 2007 and Van Uzenort in 2008. The fifth theme quantified a variety of benefits of implementing a BCMA system and process, with Agarwal suggesting that across the U.S., organizations have the potential to save $88 billion over 10 years, while Magavelli found that a tertiary care hospital attained a net benefit of $3.5 million over 5 years with the implementation of a BCMA system and process. Poon studied the impact of BCMA on nurse productivity, suggesting an improvement of 40%, while Hurley and Yelanimo, in studies completed in 2007, reported statistically significant improvement in nurse satisfaction. Despite the evidence that BCMA, particularly when implemented as a component of a closed-loop medication administration system, the full positive impact of BCMA has yet to be realized. In a comprehensive study by Koppel et al. In 2008 across 5 hospitals utilizing 5 different data collection methodologies, identified 15 types of workarounds, such as affixing the patient's identification band to computer cards, scanners, or even door jams, and 31 types of causes of workarounds, such as unreadable medication barcodes, malfunctioning scanners, and failing batteries. Koppel concluded with 10 recommendations when implementing a BCMA system and process, which were incorporated into this study. The study design was that of a quantitative retrospective study before and after implementation of BCMA across 15 inpatient units at large tertiary hospitals. The independent variable of the study was the BCMA system and process embedded within an EMR, while the dependent variables were the incidence of medication errors and the severity of medication errors. The study incorporated the use of 2 instruments. The first was the Incident Reporting System, which was embedded within the Quality Risk module of the organization's information system, Meditech. The incident reporting system was located on all of the PCs within patient care units and thus readily available to staff who were oriented to the tool and process of using it during their orientation to the organization. The second tool used, or instrument used, was the NCC MERP categorization and indexing tool. This widely published and utilized tool was developed and continues to be endorsed by the 22 NCC MERP members, which include the Institute for Safe Medication Practice, the Joint Commission, and the FDA. The tool was available on the NCC MERP website. Written permission was also granted. Data collection began with staff voluntarily reporting a medication error via the incident reporting system. While 3 methodologies for data collection of medication errors was reported in the literature, which included number 1, observational, number 2, medical record review, and 3rd, voluntary reporting. Of these 3 methodologies, the study site hospital utilized the voluntary reporting methodology because it had been found to be the most practical method over time in a study by DeFeature in 2012. Additionally, this method was recommended by the Institute of Medicine in 2006, the Institute for Safe Medication Practice in 2008, and the National Coordinating Council for Medication Error Reporting and Prevention in 2001. Once the medication error was entered into the incident reporting system of the Quality Risk Module, it was automatically assigned a notification number, thereby removing all patient identification. The medication error data was then extracted from the QRM, or the Quality Risk Module, by the quality manager or her designated quality specialist. Both of these individuals were assigned unique passwords to access the QRM module and had also received special training regarding its use. These 2 individuals remain consistent across both time periods of the study. The quality manager or designee initially reviewed the medication error data daily and entered it into a spreadsheet that was also embedded within the QRM module. This provided the data utilized in the study to report the incidence of medication errors. The medication error data was then reviewed by a 3-member team to categorize the severity of the medication errors in accordance with the MCC MERP categorization and indexing tool. This 3-member team remained consistent across both time periods for the study. Each member reviewed each medication error individually, and if the 3 members agreed, the categorization stood. But if there was a disagreement, the 3 members met to discuss the medication error and came to a consensus. The reporting capability of the QRM module provided the ability to readily obtain reports for both the incidence and severity of medication error data. It is important to note that the same 6 months of the calendar year were utilized for the pre-BCMA and post-BCMA study periods to control for variables such as fluctuations in census, as well as the number of new nurses based on seasonality for hiring. The integrity of the data was assured with each staff person being assigned a dedicated password for access into the organization's information system. The security of the system was constantly monitored by the IT department. Any attempt or actual breaches to the system were immediately investigated and reported to Human Resources, where the confidentiality policy was applied. The medication error data was considered protected quality assurance information, and the study data was secured in the researcher's office and locked when the researcher was not present. And upon completion of the study, the data will remain in a locked file in the researcher's office, and after 5 years, it will be destroyed. The content validity of the medication error data was password protected and limited to 3 designated individuals within the Quality and Risk Department. These 3 individuals received special education in the use of the QRM module and process of abstracting, coding, and categorization. The reliability of the medication error data was assured as these three individuals remained consistent across both time periods of the study. The study tested 4 hypotheses that were described in 2 subsets. The first hypothesis was the test of the relationship between BCMA and the incidence of medication errors, where the null hypothesis stated there is no difference in the incidence of medication errors between the pre-BCMA and post-BCMA groups, while the alternative hypothesis suggested there is a difference in the incidence of medication errors between the 2 study groups. The second hypothesis was the test of the relationship between BCMA and the severity of medication errors. And again, the null hypothesis stated there is no difference in the severity of medication errors between the 2 time periods of the study, while the alternate hypothesis stated there is a difference in the severity of medication errors across the 2 time periods of the study. The study is one of relationships between the pre-BCMA and the post-BCMA study periods. Therefore, the chi-square test was appropriate. The SPSS software was used to complete the chi-square test for the incidence of medication errors at the composite and the unit level for both for the severity of medication errors at the composite level. However, the severity of medication error data at the unit level provided values of less than 5 in many of the cells. Therefore, the Fisher's exact test was appropriate. However, the severity of medication errors using the NCC-MERP categorization and indexing tool was categorized into one of 9 possible categories. In actuality, there were no medication errors coded in 3 of the 9 possible categories. Thus, the contingency tables were 2 by 5 or 2 by 6, as opposed to 2 by 9. Since the Fisher's exact test only accommodates a 2 by 2 contingency table, the Fisher's exact test was performed using the SISA 5 by 2 exact software, which was provided by Utenbrook in 1997. While not commonly used in statistical analysis, the use of this SISA 5 by 2 exact software was found in scholarly studies of rare events. In 2014 by Jenkins, in 1993 by Luft, and Utenbrook again in 95. Thus, this application was appropriate for this study. The demographics of the study provided interesting and important information. As a reminder, the study was completed across 15 inpatient units at a large tertiary care hospital in the Midwest, and the same 6 months of the calendar year was used to control for variables such as seasonal fluctuation of admissions, as well as the number of new graduate nurses. With that as background information, it is important to note that there is less than 2% difference in the number of patients admitted between the 2 time periods of the study. The resulting patient days was also less than 2% different in the number of patient days in each time period. And the number of medications administered during each of these time periods approached 1.0 million. Despite this large number, there was less than 1% difference in the number of medications administered. This large number is what qualified this study as one of rare events. This table depicts the findings of the first hypotheses, which tested the relationship of BCMA and the incidence of medication errors at the composite level. One will note that of the 900, or let me just say, the nearly million medication doses administered in the pre-BCMA time period, there were 247 doses reported with error, and 288 in the post-BCMA time period. The chi-square is seen as 2.776 with a degrees of freedom of 1 and a p-value of 0.096. And for the purposes of this study, the p-value was set at 0.05. The interpretation of the findings of the test of a relationship of BCMA intervention and the incidence of medication errors at the composite level was not statistically significant with a p-value of 0.096. Thus, the null hypothesis was accepted. The test of relationships was also completed at the unit level, with 2 of the 15 units reporting statistically significant findings. One was the 1 West Surgical Trauma Unit with a p-value of 0.011 and the 2 West Neuro Unit with a p-value of 0.016. Thus, for these 2 units, the null hypothesis was rejected. The remaining 13 units were not statistically significant in their findings, thus the null hypothesis was accepted. The second table depicts the findings for the second subset of hypotheses, which tested the relationship of the BCMA intervention on the severity of medication errors at the composite level. A statistically significant difference between the pre-BCMA study group and the post-BCMA study group was found in 3 of the 9 categories of severity of medication errors. Columns A and B indicate severity levels which were significantly more prevalent post-BCMA, while column D indicates severity levels which were significantly more prevalent pre-BCMA. The chi-square of this analysis was 13.37 with degrees of freedom of 2 and a p-value of 0.02. The interpretation of the findings of the relationship of BCMA and the severity of medication errors are twofold. First, at the composite level, a statistically significant difference was found with a p-value of 0.02. Thus, the null hypothesis was rejected. However, at the unit level, significantly significant findings were found in 3 of the 15 units. Again, the first is the same as with the incidence, is 1 West Surgical Trauma with a p-value of 0.019, also ICU with a p-value of 0.013, and the Behavioral Health Adult Acute Unit with a p-value of 0.035. Thus, for these 3 units, the null hypothesis was rejected. 12 of the remaining 15 units did not report statistically significant findings, thus the null hypothesis was accepted. This slide is a graphic display of the findings of the study, and what is interesting is the visual that it very quickly represents. The red line is the post-BCMA time period, and one can quickly see that the number of medication errors reported was higher while the severity was less. And you can see that as the red line moves more to the left of the graph. The interpretation of the findings of the chi-square analysis at the composite level for the at the total level provides several interesting discussion points. First, the number of medication errors actually increased from 247 to 288. However, this increase was actually not statistically significant. This increase in the incidence of medication errors, which were voluntarily reported, may be explained by 2 factors. First of all, the process of planning and implementing the BCMA system provided the opportunity to create an increased awareness of what constitutes a medication error and the importance of reporting it. The second factor was the implementation of what was called a good catch incentive, which provided a focus and reward for reporting circumstances that had the potential to cause harm. Secondly, the BCMA intervention did reduce the severity of medication errors with a p-value of 0.02. And what's of interest is the decrease was in category D, which is defined as an error occurred that actually reached the patient and required monitoring to confirm that it resulted in no harm to the patient or required intervention to preclude harm by 33%. So actually the decrease was from 61 pre-BCMA to 47 post. While there was an increase in the categories of A and B, which really is important because that is the category where an error occurred, but it did not even reach the patient. And that increase was 33 BCMA to 70 post. So the important part here is the fact that medication errors were reported that offered the opportunity to provide intervention, so they did not actually reach the patient. The interpretation of findings provided three interesting observations at the unit level and included, first of all, the One West Surgical Unit of interest is the largest and busiest unit in the study site hospital. Statistically significant findings were reported for both the incidence and the severity of medication errors. And of interest, the increase in reporting was actually at 84%. But what's also interesting is that there was absolutely a total elimination of medication errors beyond category D on that unit. So very significant findings. The second interesting point would be that statistically significant findings were also reported in two other units which are also large and busy. The ICU was a 22-bed medical surgical unit, while the behavioral health acute adult unit, which is considered the critical unit for the behavioral health services. And again, both p-values under the 0.05. This really provides three considerations. All three of these units are large and busy. So it begs the question, is there the opportunity to actually divide the units or make them smaller to reduce the level of activity and thus perhaps the risk of even a medication error reported? Or if BCMA resources are limited, the implementation of this system and process should be prioritized to the largest unit. The limitations of the study are twofold. The first was the use of the voluntary reporting system for medication error data. Thus, the possibility of underreporting medication errors for this study need to be consistent with, or potentially were consistent with the findings of DeFeature et al., which reported underreporting by a range of 10 to 47%. And while this voluntary reporting methodology for medication reporting errors carries the risk of underreporting, again, I'm reminded that it was deemed to be the most practical over time and recommended by the IOM in 2006, the Institute of Safe Medication Practice, as well as the National Coordinating Council for Medication Error Reporting and Prevention. The second limitation of the study was that it was completed at one hospital. Thus, the study findings have limited generalizability. The inferences of the findings for implementing the BCMA system and process completed a closed-loop system, increased the incidence of medication errors while reducing the severity of medication errors. The second inference is that the implementation of the BCMA system itself improved patient, staff, and organizational safety. The BCMA system provided an alert functionality whereby if any of the 5 rights of medication administration were violated, an alert popped up on the screen and the nurse was forced to do a deliberate override of the system to continue with the medication administration process. The override report was monitored on a daily basis and provided direction for leaders to study causes for the overrides and further improve processes. Myers and Massetti et al. In 2011 suggested that a medication error resulting in an ADE or in an adverse drug event cost an additional $8,750 to the cost of treatment. This study site hospital reduced its medication errors categorized as causing harm by 28, resulting in a savings of $245,000 on an annualized basis. Additionally, the CMS meaningful use criteria required a 10% scan rate for medication administration by October 1st, 2014. Across the study, the scan rate remained at a 95% level during the entire post-BCMA study period. Thus, the organization met this criteria and was eligible for the $6.2 meaningful use dollars available for meeting this criteria from the government. The implication for nurse leaders is twofold. First of all, the prevention efforts must be the goal of every nurse leader. And additionally, there really is a call for all nurse leaders to be engaged in the design, the implementation, and outcome measures for such a project. A nurse leader must articulate the values of BCMA system and process to the organization. Nurse leaders need to assure the value proposition is not only present, but verbalized and presented. Nurse leaders must stay focused on new technology, as this technology changes every 4 years. So there's a continuing emergence of new technology, which is critically important for nurse leaders to pay close attention to. The recommendations for future research are twofold. One would be a mixed method approach to the study design, where not only the quantitative approach was taken as in this study, but to add an additional element of a qualitative approach, which would include focus groups of nurses, pharmacists, and patients, which would really provide additional information as to the why and the how of some of these medication errors and how might perhaps other improvements be made. The second recommendation is actually a new focus. As healthcare continues to move forward, we focus more and more on the continuum of care. That and the implementation or the emergence of new technology provides an interesting opportunity to really look at how do these types of technologies applied across the continuum of care add to the knowledge about patient safety for all of us going forward. In conclusion, it is well known that medication errors cause a significant risk to patient, nurse, and organizational study. The literature review suggested that technology, particularly the BCMA system within an EMR, has been effective in reducing medication errors. I learned that the Donabedian model and its focus on structure, process, and outcomes was particularly helpful in guiding the planning and implementation of a project as large as this, and the importance of leaders in being visible and engaged in the project. Obviously, this study supported much of the research that's been published, in that it did, while increasing the number of medication errors of the incidence, it actually decreased the severity of medication errors. Knowing this, I learned that our work is not done. Nurse leaders must remain focused on achieving an outcome of zero medication errors that have the ability to cause harm. I've included 2 pages of reference checks or references available that were utilized in the study. So this is the first page. We have a second page here, and actually a third page. Thank you for listening to my capstone project, Final Defense.